All right, thank you for your interest in this learning case. My name is Lauren Hinrichs-Kinney, and on behalf of my colleague, Jen Stevens-Lapsley, I'm excited to present our work implementing high-intensity rehabilitation in skilled nursing facilities. Listed here are the competencies covered in this presentation. Let's go ahead and start with some quick background information to really frame the why behind this body of work. Skilled nursing facilities, or SNFs, play a critical role in post-hospital rehabilitation, helping people regain function and return home. But these settings are facing big challenges, including more complex patients due to aging and medical advances, major changes in payment systems, and most importantly, many patients are being discharged with low functional levels, putting them at risk for rehospitalizations or long-term dependency. One reason for these poor outcomes may be the way that rehabilitation is delivered. SNF rehab care has been characterized mostly by lower intensity activity that may not challenge the muscles enough to make changes in strength that then influence physical function. We know that high intensity resistance training improves strength and function in older adults, even those with medical complexity, but it's less often utilized in skilled nursing facilities. So we piloted a progressive high-intensity rehabilitation program at one SNF, and we observed better physical function, improved discharge outcomes, and shorter lengths of stay without any adverse events. But replicating this, or the success at other SNFs, didn't go as smoothly. Results were mixed, and we needed a better approach that really balanced feasibility and impact of implementation. And so that's where we turn to implementation science to really bridge this gap between research and practice and help us develop an implementation approach that balanced feasibility and impact across diverse skilled nursing facilities. So to get us all on the same page, the goal of implementation science is to find strategies that are both effective and feasible to support clinicians and systems in adopting evidence-based care, like high-intensity rehabilitation, thus facilitating improvement in patient outcomes. To meet our objective of finding such strategies or approaches, we took several steps. First, we gathered an expert panel of clinicians and researchers and followed an established development method called implementation mapping. We then evaluated clinician and leaders' perspectives of the strategy, followed by the evaluation of the strategy's impact on desired outcomes, while understanding how and why the strategy either worked or didn't work. And we are currently in the process of refining our approach based on the findings from these steps. So what is implementation mapping? It's a systematic approach to develop an implementation strategy that was created by Maria Fernandez and colleagues, and it includes these 5 steps here, which we modified slightly by adjusting or switching steps 1 and 2. Our expert panel of 9 clinicians and researchers with experience implementing high-intensity rehab walked through the first 2 steps together, while a subgroup of that panel with training and implementation methods completed the final steps, and the final strategy was approved by the full expert panel. In step 1, we defined performance objectives, and we used the ACT framework to guide us, and I'll give more information on that framework in the next slide. The output of that step was a table of behaviors of basically who needs to do what differently in order to implement high intensity. Next, we identified barriers and facilitators to those behaviors, and the output of that step was a list of factors that we need to address with our implementation strategy, and then we mapped those factors to a PRISM determinant framework, which I'll also introduce here in a second. We used theory and evidence to develop the components of the strategy that directly targeted those factors that we identified. In step 4, we developed the strategy components, which we then mapped to the ERIC taxonomy, which is a list of evidence-informed implementation strategies. And then finally, in step 5, we planned for our evaluation of that strategy. So this is a really busy slide, but I think it will help see what this first step is and why it's so critical. So using this ACT framework, or action, actor, context, target, time, is a good exercise to really make sure that there are no gaps or missing actions that need to happen to implement change. And it also offers just a really clear and specific way to communicate actions to all involved. So let's walk through this table. Our first objective was that occupational and physical therapists need to screen a patient for appropriateness. So their action, they need to review the medical history and assess vital signs. And they can do that in the patient's room or through the medical record. And we ask that they do that for all patients receiving rehabilitation care upon the initial evaluation. Once the OT and the PT do that, they need to communicate to their team, and we ask that they either use verbal or written communication to do so after that evaluation, or if there's any sort of a change in the patient's status. And then the treating therapist then needs to review the patient evaluation and/or the last treatment note prior to each treatment session. The treating therapist then needs to educate the patient on high-intensity rehabilitation to generate that buy-in. And then once the patient agrees, the treating therapist needs to dose rehabilitation according to high-intensity principles. They then need to monitor that patient's response and document what had happened in that session. So again, you can kind of see how this step will really identify all the parties that need to be involved and help provide clear instructions for who needs to do what, when, and where. So our next step was to identify factors that may influence the performance of those objectives and just implementation in general. Implementation science has numerous frameworks. One group or cluster of frameworks are called determinant frameworks, and they present factors that may influence implementation. So we used this PRISM framework here, or the Practical Robust Implementation and Sustainment Model, to help guide our identification of influencing factors or barriers and facilitators. Specifically, PRISM represents how perspectives of the intervention and then characteristics of the organization, of patients, how the external environment and how the infrastructure, how those all interact together to really influence implementation. After looking into the literature and reflecting on some of the expert panel experience, we came up with a list of factors that we deemed most influential to implementation of high intensity more broadly across diverse settings. So those included clinician perspectives, organizational characteristics such as leadership support, clinician knowledge, self-efficacy, behavioral drift, patient characteristics, or specifically their level of engagement with rehabilitation, facility infrastructure, specifically the equipment that they have. And then we also left room to identify and address facility-specific determinants that maybe we couldn't anticipate ahead of time, but know those things do pop up. So next, the panel subgroup researched several learning and behavior change theories and evidence to identify a strategy that could then directly target each of those factors that we identified in the slide before. So this is our final table, again, a little busy, but you can see the PRISM factors in this column here, the specific strategy to address that factor, and then the supporting theories and evidence that informed our selection of that strategy to address that factor. So let's walk through a few as an example. We knew that we needed to enhance clinician positive perspectives of high intensity, and we used the adult learning theory, transformation learning theory, to really develop some of the reflections that we facilitated through the online modules, as well as some of the discussions that we had in the check-in. We also knew that we needed to address clinician self-efficacy, and we used the social cognitive theory to guide our creation of videos as worked examples. Again, we knew that each facility might run into issues that we didn't anticipate, and so we selected the strategy of an external implementation facilitator who was a member of our research team, and that strategy has been used frequently and is highly supported in the literature. So in the next step, we developed and assembled all of the strategy components, and this is what we have as a result. We mapped or categorized each strategy component to the ERIC taxonomy to really help support clear reporting and reproducibility of this particular strategy. So our strategy rolled out in 3 phases across 8 to 18 weeks, During this onboarding phase, that included a kickoff with team leadership and staff. The 12-week training portion included distribution of equipment, virtual self-paced training, live case discussions and check-ins, and then that facilitated implementation, that final phase included weekly tips and tricks that were emailed to clinicians and facilitated self-assessments. And then across that entire 18-week timeframe, all facilities had access to that external implementation facilitator as well as a clinical content expert, both of which who were part of our research team. So in that final step, we decided how we really wanted to approach the evaluation of our strategy. We knew we wanted to understand how leaders and clinicians perceived our strategy. We wanted to determine the extent to which the strategy influenced implementation and in what ways, and then really understand if there was anything different about the site or maybe the steps that they took that can explain variation in implementation outcomes. So to evaluate strategy perspectives, we used a convergent mixed methods approach, collecting survey data through the acceptability of intervention scale and a study-specific feasibility questionnaire, along with focus groups, all which occurred immediately following that 18-week strategy. We used a combination of descriptive statistics and content analysis, and then triangulated those unique findings via joint displays. So what we found were high levels of acceptability of the strategy, and that was due to prolonged clinician engagement with the strategy, due to access to the external facilitator, various job aids that were part of our training, and really having multiple ways to engage with the materials, including written content and then videos of worked examples. We had moderate levels of feasibility, and that was really due to the flexible nature of our implementation strategy and having the presence of protected time and space for clinicians to really engage with the strategy, and really then engaging with the strategy as a full team altogether. We did observe this meta inference of dissonance for the format strategy, or really just the format of the strategy. It was deemed logistically challenging to find small chunks of time to really engage with the implementation strategy across all those 18 weeks. And it was thought that maybe just a simple workshop or a seminar would be better. But at the same time, clinicians did acknowledge that that slow, gradual change was likely better for long-term behavior change. We did identify some ongoing needs based on our participants' feedback, and that was really to try to find ways to include enhancing the knowledge of other people that were involved in the patient's care. So specifically letting nursing know about the high intensity program. And then clinicians also identified needs to develop some sort of strategies to help the facility sustain the practice once the rehabilitation team backed away. So our big takeaways from this perspective exploration is that organizational support is critical to engage in strategies to facilitate evidence uptake, and that we need to engage with sites early on to kind of co-create ways that they will sustain use of high intensity again after this research team support is removed. So next, we wanted to understand to what extent and how our strategy influenced implementation. So we constructed this logic model to really help identify the outcomes that we wanted to collect in our analysis plan. So our hope was that our strategy changed clinician knowledge, self-efficacy, and perspectives, which then positively influenced adoption and implementation. We wanted to leave room to see how else the strategy might influence implementation, and then also see if there are any clinician factors such as years of experience, having a specialty certification, discipline, those types of things, if any of those clinician factors moderated our implementation outcomes. We collected data on a change in clinician knowledge, self-efficacy, and perspectives across those 18 weeks. We assessed clinician adoption after the 12-week training using a commitment to change scale, and then we addressed clinician implementation after the 18 weeks using a study-specific questionnaire along with focus groups. So what we saw is that our collective strategy did positively influence knowledge, self-efficacy, and perspectives, but really it was that shift in perspective that positively influenced adoption and implementation. We found that the strategy also really helped increase adoption and implementation through enhancing high-intensity salience, strengthening team cohesion and accountability, and just supporting implementation in general. Success was influenced by clinicians' creativity and adaptability, having a growth mindset, being more resilient, having prior resistance training or high intensity strength training experience, and discipline did kind of predict the implementation outcomes. So realizing that we needed more information beyond clinician factors to explain implementation, we really wanted to understand what explained a range in site level implementation. So to evaluate this variation in site level implementation, we took a case study approach and used the provider report of sustainment scale to quantify site level implementation. We surveyed site characteristics using the inner setting scale, which explores culture, climate, leadership, and leadership engagement. And then we surveyed the extent of clinician burnout and engagement and team effectiveness. And then we also hosted focus groups. We then took our qualitative and quantitative data to create heat maps. Our biggest takeaway from this analysis was that the team's perspective of the complexity and compatibility of high intensity really mattered. The site infrastructure, including attention for change, implementation climate, communication channels, and time, also really mattered. And the general satisfaction with leadership really mattered. So all of those things really differentiated these high performing implementation sites from these low performing implementation sites. So teams that viewed high intensity as less complex, more compatible with their plans of care or their patient population, maybe these teams recognized a greater need for change and they had or were perceived to have more time and better communication and higher leadership engagement. All of that led to better implementation in the end. Specifically, what these higher implementing sites did on their own is that they proactively adapted high intensity to their setting by engaging patients more intentionally. They improved their continuity of care and those communication processes. They actually designated a champion to help facilitate and guide the implementation, and overall just really tailored high intensity to their context. So zooming out, here's what we've learned. Perspectives matter. Clinicians need time and support to really shift their mindset surrounding high intensity rehabilitation and skilled nursing facilities. Leadership support is absolutely critical, and leaders need support too, to kind of help guide them and how they guide their team through high intensity implementation. We realize that phased implementation works, but it does require some protected time and space from organizational support. We learned that external facilitation does help, especially those unanticipated context-specific tweaks that are needed. Champions are critical to help drive the momentum of implementation, and there may need to be ongoing mentorship to really boost clinician creativity, boost team continuity of care, and overall team engagement with the implementation process. So in response, we are currently developing and piloting a more leadership-facing toolkit where we can mentor leaders to select strategies that work for their unique team and their unique context. We are currently working on enhancing our library of worked examples to kind of help facilitate that clinical application. And we are evaluating and refining our strategy across additional sites as well as different health systems to kind of see what that system level impact is as well. And that's all I have. I really thank you for your time and attention. You're welcome to email me with any questions that you have about this presentation. And again, I thank you.